All right, I'd like to welcome everybody back for the second half of our session here. I think the first half went well. Hopefully people learned a lot and got some answers to some questions and also raised some more questions. First, I want to introduce one of our new panel members. Dr. Jennifer Kaplan is from our Division of Critical Care. Also works closely with our trauma program as our Pediatric Critical Care Liaison, and she'll be with us for the afternoon to help provide input on our perspective and a critical care perspective to what we're talking about this afternoon, which will mostly focus on C-spine and then the management of severe brain injuries. With that, we've kind of already heard from and engaged Dr. Piot, but formally introduced Dr. Piot is from Nemours Neuroscience Center in Wilmington, is professor of neurosurgery, and we're honored to have him here to talk to us today about C-spine clearance. So Dr. Piot, your slides will be up, and you can take control of your slides.
So mine is the privilege of beginning the conversation about evaluation of the cervical spine in pediatric trauma. Why to image, whom to image, and how to image. And I'm sure that since there's a lot of art and craft in this process, there will be some conversation afterwards. I'm going to say a few words about the epidemiology, some familiar words about anatomic patterns of injury at various ages. We'll go through the Nexus process and discuss who does not need an imaging evaluation. We'll discuss the various possible imaging modalities, or at least the commonly used imaging modalities, and their advantages and burdens and drawbacks. And I'll wrap up with some system comments. So these are data from 2009, both from the National Trauma Data Bank and from the Kids Inpatient Data Set. The incidence nationwide of fracture, dislocation, spinal cord injury among children is 170 per million children, and spinal cord injury at 24 per million children. Some common clinical associations to keep in mind on initial evaluation. Head injuries are very common among children with spine injury. About 40% of children with spine injuries have some severity of head injury, and in this data set, 16% had GCS less than or equal to 4, so a significant head injury. The converse is true as well. About 10% of all files coded for traumatic brain injury in this data set had spine injuries, and 11% of all severe TBIs had spine injuries in this data set. That's a pretty standard observation, consistent with a lot of literature on this topic. But here's an alarming association. Among trauma patients who need sedation or intubation in the emergency department for one reason or another, 1 out of 6 has a spine injury. So vigilance is needed for patients who are traumatized to the point where they need sedation or intubation. Keep spine injury in mind. And another pearl to keep in mind is that spine injury at multiple levels is common. Between 20 and 25% of the injuries recorded in this data set were multiple level injuries. And as is true for most of childhood trauma, it's adolescents who see the highest incidences. Among younger age groups, injuries are relatively more prevalent among other age groups than spinal injuries altogether. Some points to make from this table. Upper cervical spine injury, relatively more common in infants and young children than adolescents, and conversely, lower cervical spine injury, more common among adolescents than younger children. To keep in mind, lumbosacral injuries are very common. We obsess about the cervical spine for many good reasons. The potential neurological morbidity is much greater, but lumbosacral spine injuries are common, and they are the predominant injury in adolescents. The patterns of spinal injury, the mechanisms of spinal injury vary by race and socioeconomic status in sad but predictable ways. Let me call your attention to this statistic. Almost a quarter of spinal injuries that, as we defined in this study, almost a quarter of spinal injuries in Black children are due to firearms. And abuse, likewise, higher in some racial groups than others, and activities associated with greater degrees of financial well-being give proportionate opportunities for spine injury. This is another way to cut the same pie here. We're looking at insurance coverage, commercial, other. Other is, I think, mostly automobile insurance for people in car crashes, and then public self-pay or no charge. Once again, a rising prevalence of firearm injuries, moving from commercial insurance to public or no pay, and likewise abuse. And another way to cut the same pie here, we're looking at median income of home zip code divided up into quartiles. So quartile number 1 is the lowest income home districts, and quartile number 4 is the highest income home districts. And once again, we see the same kinds of trends related to socioeconomic status. Firearms tapering at in wealthier neighborhoods, abuse, bicycle and horse activity increasing in wealthier neighborhoods.
We are working on some technical difficulties for Dr. Piat, who seems frozen in time at the moment. As we work through that, I'll just kind of point out one of the key things that really struck me as he was talking. 1 in 6 that require intubation or sedation may have a spine injury. Certainly that's an important number to keep in mind as we go through this and as we discuss this. I know another thing that Dr. Pia may touch on as we get him back, and that we'll bring up as we move forward, is there's certainly medical legal concerns that go along with missing or that drive people to image or do more work with C-spine injuries. It looks like we got Dr. Piat unfrozen.
I'm back again. I regret my unstable internet connectivity here.
No problem.
So, when you want to know how to do something, you go to Wikipedia, and that's what I've done. I've checked clearing the cervical spine on Wikipedia, and the Wikipedia recommends that we begin talking about Nexus. I'm sure Nexus is familiar to most of the audience here. A huge prospective study looking at tens of thousands of emergency department patients to define a rule for who does not require cervical spine imaging, a rule with a very high negative predictive value. Extensively studied and validated in adults, not so much in children. Familiar to most of the audience, if a patient is alert, cooperative, and oriented, not intoxicated, no distracting injuries, no posterior midline tenderness, and no neurological deficits, no neurological symptoms or signs, are C-spine imaging. The Canadian rule, more complicated, less popular, most likely because it's more complicated, performs better in some statistical ways, but Nexus has sort of won the day in terms of popular use in this country. Problems with Nexus among children, not validated for children, little studied among children. Its sensitivity for significant spinal injury has been reported between 83 and 100%. So not perfect, perhaps. The problem with validating a rule like Nexus in childhood is that actual injury rates are very low. So enormous numbers of patients need to be accrued to get the error bars down to a reasonable narrowness. So we use Nexus, but with vigilance. So a child needs imaging according to Nexus or other clinical judgment. In younger children, typically we are satisfied with 2 views of the cervical spine. The problem with 2 views of the cervical spine is that one of them is not necessary. One of them adds nothing. The AP films almost never add anything to the evaluation. The other problem is getting adequate images from the base of the skull down to T1. That's a problem at all ages. In older children who can cooperate, we add an open mouth view. The sensitivity of 3 views of the cervical spine has been studied and is around 90%. So it is pretty good, but not perfect. We neurosurgeons are often asked whether we want flexion extension films for patients who have normal 3 views, but still have a lot of neck pain and rigidity. We in our practice do not make use of flexion extension films for the perhaps obvious reason that the person who might need flexion extension films cannot execute the maneuver. They have neck rigidity and they can't flex and they can't extend, so the imaging is not informative. We do not make use of flexion extension films in our practice. CT scanning is wonderful. An adequate thin-cut CT scan with 2D reconstructions in the coronal and sagittal plane. Most of us believe the sensitivity for significant cervical spine injury is very close to 100%. They have to be interpreted carefully, and they come at a cost, namely radiation exposure. I'll talk more about that in a moment. We neurosurgeons are often asked whether a patient who is comatose and needs the neck cleared should have MR imaging. Our posture is that the MR imaging is too sensitive. It shows ligamentous and soft tissue injury with exquisite sensitivity, but many of these findings are of no clinical significance, and they often add heat rather than light to the question of C-spine stability and whether a collar can be removed. So in our practice, we try to discourage MR imaging for C-spine clearance. MR imaging is always indicated in the setting of spinal fractures or dislocations or neurological symptoms and signs of spinal cord injury, but as a screening tool, we try to discourage it. A few words about looking at C-spine radiographs and CT scans. Perhaps I obsess about occipito-cervical and atlantoaxial separations, but this is an injury in childhood that is extremely unstable and has grave implications for evaluation and management, and can be quite subtle. Not like this, but can be quite subtle at times. Always look at the edge of the film. This young man had an occipito-cervical separation that was overlooked because the findings were obscured by proximity to the edge of the image. This is an example of plain films of the occipital-cervical junction that look suspicious, but few interpreters would be confident enough to say that it was definitely abnormal. On CT scanning, we do get a better view this is Lee's X line, and I use it occasionally to try to assess alignment at the occipito-cervical level. A line drawn from the posterior inferior corner of C2, resting on the arch of the atlas, ought to intersect the opistheon here, the point at the back of the foramen magnum. And another line from the midpoint of the spinolaminar line on C2, resting on the dens, ought to intersect the basion. In this case, neither does, and in fact, this child had a bad soft tissue injury and instability at this level with a spinal cord contusion. The most reliable way to assess the occipito-cervical interval is the separation of the condyle from the lateral mass of C1. This film is obviously abnormal. Some are more subtle, and this interval is really best assessed on CT scan. Meticulous work by Docling Pang has developed a rule of thumb that somewhere this joint space ought to be 2 millimeters or less in a normal C-spine. So CT scan is wonderful. You see everything in exquisite detail. This is a normal X line here. This is a normal condyle to lateral mass. 2 millimeters. We can assess the symmetry of joint spaces. This is very important in detecting soft tissue injury that is potentially a cause of instability. Fractures of the ring are easily imaged at every level, and the joint spaces between the articular pillars of the lower cervical spine can be judged very confidently on these coronal and on sagittal reconstructions. Here's a recent example from our practice. This child was in a high-speed motor vehicle accident, a young child, I think 3 or 4 years of age. On the right side, the facet joints are all nicely opposed, but on the left side, there's daylight here. This facet joint is uncovered, and in fact, this child had unstable ligamentous injury and spinal cord injury at that level. But these films on first reading had been interpreted as normal. A few words about evaluating abusive spine injury. We know from work in the last 10 years or so that cervical spine injury is fairly common among infants with severe abusive head injuries. My colleague here at DuPont, Arvind Chowdhury, and my friend Mark Diaz have studied this, looking at signs of mostly soft tissue injury in the cervical spine of infants with severe traumatic brain injury. Seldom important for clinical management, but sometimes very important for forensic purposes, actually determining how an injury was inflicted. This child actually didn't have severe head injury, but came in quadriplegic from being throttled and shaken at the same time. She had a spinal cord injury without radiographic abnormality, a bad spinal cord contusion, and maybe you can see the petechiae on her neck here. But the most common abusive spine injury are compression fractures, particularly of the lower thoracic and lumbar spine. How these injuries occur, one can only speculate, but on a mechanistic basis, I think that these children must be grasped around their torso and slammed buttocks first into some hard object, such as a table or a wall, and they suffer an axial loading injury with compression fractures. Not unstable, generally not associated with neurological injury, but important to recognize for what they are. So I've expressed my affection for CT scanning. What's wrong with CT scanning? What's the problem with CT scanning? As we all know, is the radiation burden. These are comparative figures for radiation, tissue radiation absorption for various common radiological studies. Chest X-ray, 0.02 millisieverts, C-spine CT scan, 15 times. Did I do the arithmetic correctly? Yes, 15 times as much tissue radiation exposure. And whether it's true or not, it's widely believed that this kind of radiation exposure is responsible for cancers later in childhood, a very high incidence, a very high prevalence, lifetime prevalence of cancers related to this kind of radiological exposure. So there is much interest and much pressure to minimize the use of CT scanning of the cervical spine. And most of the recent literature about clearing the cervical spine focuses on how to avoid CT scans. I would be interested in what is the negative predictive value of your cervical spine screening process. But most people who are writing about this topic are now writing about how they avoid CT scans. And you know, that's an important objective. Sensitivity or negative predictive value not discussed. 4 injuries, you can't tell anything from 4 injuries. Decision analysis, 10 injuries, you can't really tell anything from 10 injuries. Let me look at show you the 2 papers in this quick PubMed review of recent literature on this topic that had the most actual injuries and talk about their significance. So this was a paper from Salt Lake City. Really, it was an institutional series of children cleared by the neurosurgical service for their potential C-spine injuries. And over several years, they evaluated 936 children for potential C-spine injury. They actually saw 936 evaluations, 26 injuries for a rate of 2.8%, which is pretty common when we're talking about evaluating C-spines in trauma patients, a low injury rate. They didn't miss any injuries. They reported they didn't miss any injuries. But if you put confidence intervals on that 0, the 95% confidence interval is between 0 and 12%. So they may still have a fairly insensitive screening process, but because the number of injuries that they evaluated was so small, they don't know it. Not very satisfying. This is one of my favorite old papers from JAMA from 1983. It's a discussion of how to put confidence intervals on 0. I recommend it for people who like numbers. This is a very nicely done multi-center study run by the American Association for Surgery Trauma, including some authors on the panel here today. That captured 12,000 some odd children under 3 years of age. So this is a really marvelous piece of work. 12,000 children under 3 years of age. And they developed a score for identifying children with significant cervical spine injury. You get 3 points if you have any depression of your level of consciousness from additional points if you're not opening your eyes, 2 points if you were in a car crash, and 1 point if you're under 2 years of age. The study group was under 3 years of age. If you're under 2 years of age, you get a point for that. And they showed that children who score 0 or 1 on this scheme do not require spine imaging, with a negative predictive value of 99.93%. So that's a fairly impressive piece of work. And hopefully, as I believe Dr. Hamilton suggested earlier in the talk, we'll see more of these studies that really give us reliable information about whom not to image. So this is our C-spine clearance protocol. I expect everybody in the audience and all the panelists have similar box and arrow diagrams at their institution. We start out with the Nexus criteria. Patients who are obtunded generally get C-spine CT scans. There is some wiggle room here for judgment about severity of mechanism of injury and general suspicion, but children who are obtunded do get CT scans. If Nexus criteria are met and they're not obtunded, they go through the plain radiography pathway. Any neurological symptoms or signs get a neurosurgery or orthopedic consult, CT scanning, and fall out of this screening pathway. So there is not yet any cookbook, evidence-based answer to the question how to clear the cervical spine. The principles are a careful clinical evaluation for neurological symptoms or signs. We do rely on Nexus for eliminating a large fraction of patients who don't require imaging. Adequate plain radiography is the cornerstone of the evaluation, and easier said than done in terms of the imaging the entire cervical spine. CT scanning for high-risk patients, sensitivity to injuries close to 100%. For patients who don't get CT scans, clinical reexamination and follow-up is key, not to overlook something that might have been picked up. So vigilance is key in the absence of ironclad, evidence-based protocolization of care. And that is what I had to say. Thank you for your patience with my internet difficulties.
No problem. Thanks, Joe. That was a great discussion. And I'd like to kind of first, get the audience opened up. There was one question online, which you may have covered, I think, but just to reinforce, the question was, is it necessary to image the C-spine of a child who is incompletely immobilized, yet moving the head and neck without pain?
I refer you back to the Nexus criteria.
Yeah.
If there are no distracting injuries and no posterior midline tenderness, the child really doesn't need to be injured. I have to say that when I see a child moving his head around without any restriction or guarding, I am very reassured. But for the purposes of this talk, I refer you back to the Nexus criteria.
Understood. The other question I had was, where I know folks are very anxious when it comes to C-spine from a medical legal perspective, and I don't necessarily want to hear all you have to say about lawyers, but perhaps your thoughts on, people are very concerned about missing a minor fracture, spinous process fracture, and that there are going to be medical legal issues. What's your feelings, real concerns for that, experience with that, or otherwise?
I don't know where to go with that question. A study of closed cases of spinal cord injuries acquired after a person reaches medical attention. But I study, and there are obviously obstacles to conducting it. Right. I don't know how to respond to your question, honestly.
Yeah. No, it's a challenge. Anyone else have questions, or from our other neurosurgeons on the line, thoughts? Or from our panel here?
Yeah, I had one comment. I think one of the things to be careful is that, and what needs to be highlighted is that if patients require both clinical as well as radiologic clearance, because one of the things that I always get a question about is, in an obtunded patient in the ICU in which you're doing, critical care, can I take the collar off? I guarantee you that patient is not having any problems. They're not super concerned about it at that point. It's more of a concern with good nursing care and reassuring the family that we're protecting the child in these instances by leaving the collar on. That's the most important thing that we need to consider.
Thanks, Dave. That's a good point. And actually, as you were saying that, a question popped up similar to that online. But do you use MRI? I know, Joe, you commented on MRI. Do you use MRI in those obtunded patients to clear the C-spine, have your CT? What we've done, and interested kind of the input, but we've CT'd them. If that's negative and they're still obtunded for several days, we'll get an MRI. If that looks clean, we'll take them out of that collar. What's your thoughts on that approach? Is it appropriate, safe, not safe?
Is that an adequately performed thin cut CT with 2D reconstructions in the coronal and sagittal plane that I have reviewed and believe to be normal, I take those patients out of their immobilization and lift their restrictions. Our perception is that MR is just too sensitive, and it will demonstrate lots of soft tissue injuries that do not have any clinical significance. Again, my perception is that CT scanning is very close to 100% sensitive in detecting even ligamentous injuries. And so we take patients out of collars after they've had normal CT scans.
I disagree with Dr. Plyatt. I mean, in the sense that I like the sensitivity. I think if there is indeed ligamentous injury, then I feel that, if we had ligamentous injury in the knee or the elbow or things like that, we would leave it immobilized, that joint, for a period of time to allow it to heal. I think that some of the critiques or how should I say, sort of the issues that occur when you deal with ligaments that are being moved around with injury in a patient who's obtunded who can't protect themselves. I think that there's literature, at least maybe not necessarily in the cervical spine, but in other ligamentous type injuries, that if we create laxity, we create potential long-term problems. So we've been much more conservative. Again, if the patient is obtunded or has a severe traumatic brain injury, the collar is not creating a problem except by people wanting to get it off. If people are reassured, including parents and the staff, that the collar is there for protection so that the child's head is kept in a neutral position, particularly with a severe traumatic brain injury, we would like to keep them in that manner. I think there's no rush to taking them out of the collar.
And then I, didn't plan this, but raised that question because I know there's controversy on the CT alone or CT and MRI. When I get the sense that you're very, keep them in the collar. Is there a time frame though that you would MRI to get them out of the collar, or how long would you leave them in the collar if they stay obtunded?
Well, I mean, most of the time that limits us getting an MRI is that they have ICP monitors in, or brain oxygen monitors, or other things that they're too critical to go down to MRI. So as soon as they are clinically stable and have all their monitors removed that allow them to get the MRI, and we do get the MRI.
Great. Well, great. Thank you, and thanks for agreeing with our bias.
If there is no ligamentous injury, then even if they're obtunded, then
Dan, you going to weigh in?
To take them out of the collar.
All right, we have one more neurosurgeon to weigh in, but I like your answer since it fits our bias. Dan, do you have any comment on that?
Yes. So I don't envy anybody who has to go through all of these attempts at forming a protocol. I know we've spent hours and hours trying to come up with the best protocol, and there's always someone who has a reason to disagree with it. I have fortune or misfortune, depending on how you look at it, of taking care of adults as well. And my adult colleagues have really switched to doing CT scans alone. In fact, one of my colleagues recently said that there is no role whatsoever whatsoever in plain films in the clearance of acute cervical spine injury. I don't know that I agree with that in children, but it was an interesting trend that's going on. The other thing that we're also seeing is our radiology colleagues are telling us that the CAT scans have much lower radiation than they used to. So there are new CAT scans, flash scanners that we've obtained at our institution, and they really drop the dose. And so with the increased sensitivity that they have over plating films, I wonder if that might be a trend that we see more and more institutions going to cervical spine CT scan instead. I agree. You can't put all your faith in it. We certainly see injuries, synchondrosis fractures, or dislocations at the odontoid that might not be picked up on a CAT scan very easily. The other thing we have a terrible time with is the age. I think there's a big difference between the imaging and clearance on a 2-year-old versus a 16-year-old. So we've pondered this for a long time. We don't have any conclusions, but I agree with Dr. Pyatt that CT scan does seem to be the most sensitive when available. In terms of MRI scan, we also wonder about the length of time that some of these patients require before they'll be stable enough if they have an intracranial pressure monitor in. A lot of radiologists say that the first 2 weeks you really need to get that MRI scan in order for you to catch the signal change. And so sometimes you're outside of that window and need some further dynamic imaging.
Great.
And then one further comment in regards to what Dr. Adelson said about the collar not causing any problems. With good nursing care, I think you can minimize the risk of decubitus ulcers from the collar, but certainly we've seen a few of them that have led to operations in order to treat that. So I always try and get those collars off as soon as it's safe, but agree that we sometimes don't have much choice but to leave it on when we don't know if the neck is clear or not.
Well, great. Obviously, it's a controversial topic, and I don't think we're going to solve it in our time here. We can come back to it at the end.